Hello everybody. In this video, we'll talk about pain management medications. First, we need to understand the pain pathway. We have nociceptors, which are the pain receptor. It's a sensory neuron that acts as a detector to pain and presents at nerve endings and gets activated when there is a damaging or potentially damaging stimuli, which can be chemical, thermal, or mechanical damage. Signals will be sent to the spinal cord and to the brain. But there is a threshold limit to feel pain, meaning if you touch a needle, it will not hurt until you push your finger enough and that threshold limit is crossed. Now, when cells are damaged, they release arachidonic acid, and two enzymes, which are the COX-1 and COX-2, convert it to prostaglandin H2, which will be converted to other chemicals like TXA2, PGD2, PGE2, and PGF2. These chemicals will induce the actions of raising your body temperature, causing inflammation, and reducing the pain threshold. Now let's continue the journey of pain. Pain will be transmitted from nociceptors to the dorsal horn, then to the sensory cortex in the brain. Now let's go inside the dorsal horn. Transmitters will be released from the presynaptic neurons like substance P and glutamate to the postsynaptics and will transmit the pain to the sensory cortex in the brain. But we naturally have endogenous opioids like endorphin that acts on the opiate receptors like mu, kappa, and delta, and activating these opiate receptors will block the transmission of pain to the brain. Now that we understand the pain pathway, we need to know how our medications will work on them. First, we have NSAIDs, or the non-steroidal anti-inflammatory drugs. They inhibit prostaglandin release by blocking COX receptors. But first, we need to understand the prostaglandin normal function and the COX enzymes to predict their side effects. As prostaglandin have a major role in modulating pain, inflammation, and fever, they also control many physiological functions such as acid secretion, mucus production in the GI tract, uterine contraction, and the renal blood flow. For COX enzymes, COX-1 regulates normal cellular processes such as gastric cytoprotection, vascular hemostasis, and platelet aggregation, while COX-2 expression is increased during status of chronic inflammation and induced by the inflammatory mediators. First, we have the non-selective NSAIDs like Ibuprofen, naproxen, and diclofenac. They block both COX-1 and COX-2, so the side effects will be GI ulcers and bleeding, and sodium and water retention in kidneys. They exhibit the anti-inflammatory action by blocking prostaglandin release, and they have analgesic and antipyretic effect because they reduce the PGE synthesis, which is stimulated by pyrogen and is thought to increase sensitivity to pain signals. Selective NSAIDs like Celecox only inhibit COX-2 receptors, so it avoids the GI adverse effects and other side effects related to the COX-1 receptors. Aspirin irreversibly inhibits COX receptors. It is an antiplatelet because it blocks TXA production, which is responsible for platelet aggregation, and it's mainly used for prevention of cardiovascular events such as stroke and myocardial infarction. The side effects can be increased risk of bleeding. Then we have acetaminophen, which inhibits the COX pathway in the central nervous system but not in the peripheral tissues. And that's explained why it does not have anti-inflammatory effect and is not considered one of the NSAIDs. But it has antipyretic and analgesic effect. Overdose can cause hepatotoxicity. Now let's talk about opioids. Their primary use is to relieve intense pain, whether that pain results from surgery, injury, or chronic disease. We have natural opioids, semi-synthetic, and synthetic compounds. Their major effects are mediated by the three receptors, which are the opiate receptors mu, kappa, and delta. Opioids do not kill the pain, they only change the brain perception of pain. Let's first talk about the natural opioids, which are morphine and codeine. They have a major analgesic effect by being a strong mu receptor agonist. Codeine is considered a prodrug of morphine, meaning it will get converted to morphine by the enzyme CYP2D6. But it's less potent than morphine and it's only used orally. Morphine has several actions. For example, euphoria. It produces a powerful sense of well-being. Morphine can cause respiratory depression that can occur with ordinary doses of morphine in opioid-naive patients, but tolerance to this effect can develop quickly with repeated dosing. Both morphine and codeine have antitussive properties. Morphine directly stimulates the chemoreceptor trigger zone in the area that causes vomiting. Morphine can relieve diarrhea by decreasing the motility and increasing the tone of the intestinal circle smooth muscles, but this means that it might cause constipation. Now we have semi-synthetic derivative of morphine and codeine. Oxycodone analgesic effect is twice of the morphine. For oxymorphone IV, it is 10 times more potent than morphine, while the oral formulation is about 3 times more potent than morphine. Oral hydromorphone is approximately 8 to 10 times more potent than morphine. Hydrocodone has a comparable efficacy of morphine. Then we have synthetic opioids like fentanyl, methadone, and mipridine. Fentanyl has 100 folds of analgesic potency of morphine, so it's used for anesthesia and has rapid onset and short duration of action of 15 to 30 minutes. Methadone potency is comparable to morphine but with less euphoria and has longer duration of action, so it's used to control withdrawal effects of opioids. It is an NMDA receptor antagonist, so it can reduce neuropathic pain. Mipridine is low-potency opioid that acts as a kappa agonist. It has an anticholinergic effects resulting in increased incidence of delirium. Tramadol is a centrally acting analgesic that binds to the mu receptors and has less respiratory depression than morphine. Now we have buprenorphine, which is classified as partial agonist, meaning that it binds to opioid receptors but with less intrinsic activity than full agonist. It is used in opioid detoxification. In case of opioid overdose, we have opioid antagonists naloxone and naltrexone. They are used to reverse the coma and respiratory depression by rapidly displacing all receptor-bound opioid molecules. And that's the end of this video. Please don't forget to subscribe, share, and like.